Dear colleagues, Mr. Chairman, for me it's quite clear that we have to work together in this particular field. I'll try to persuade you that you should have a good relationship with your cardiac surgery colleagues in the next 10 minutes. So let's start with the definition of paravalvular leak. It's regurgitant jet or multiple jets between the prosthetic swing ring and native tissues. It's actually the most common non-structural valve dysfunction or deterioration. It has definitely major implication on long-term survival. With the TAVI experience, it has been clearly shown that with the PVL, you have increased mortality if you leave the patient with moderate versus no or mild PVL. It's the first cause of re-intervention in patients after mechanical valve replacement. All these are truths. Surgical correction remains the gold standard treatment since it has been shown that reduces the long-term mortality compared to conservative treatment. What are the risk factors associated with the development of a paravalvular leak? It has to do with annulus, with the environment, and it has to do with surgeons' either experience or surgeons' intraoperative choices, like continuous stitching, which is something that we should avoid because it has much more incidence of early paravalvular leak instead of putting intermittent and a big number of stitches. If you implant a small diameter prosthesis in a hugely dilated annulus, or if you choose to put a prosthesis without stitches, like the TAVI or like the sutureless aortic valve implantation, or like the rapid deployment aortic valve replacement. All these three kinds of implants increase the probability of PVL. In the aortic ring, the PVL incidence is much more in non-coronary sinus, and in the mitral ring, it is near the posterior medial commissure. And this actually reflects the vulnerability of these areas of the rings to mechanical stress. What is the incidence? It was clearly shown by Mr. Halepas that in the mitral valve replacement, there is in the literature between 5 or 32%. It is actually much more in the aortic valve replacement, up to 47%, but the majority, 90%, are very small with a benign course. Probably it has to do with the sensitivity of transesophageal echo in detecting these PVLs. What are the indications? Moderately severe or severe periprosthetic regurgitation with heart failure symptoms, progressive and recurring symptoms. Persisting hemolysis with small numbers of hemoglobin, increased LDH, decreased haptoglobin, and requirements of blood units. A combination of heart failure and hemolysis, failure of the transcatheter approach, either scheduled or on emergency basis, complications of the transcatheter approach like valve stenosis, valve regurgitation, LVOT obstruction, PVL and prosthetic dysfunction or instability, PVL and active endocarditis, or PVL with need of something else. What are the surgical options? The simple surgical closure, either stitch closure or reinforcement with native tissue like pericardium or synthetic material, or valve re-replacement, redo AVR, redo MVR, or redo double valve replacement. Also, in the transapical approach, there is a role for the cardiac surgery. Let's see our experience good and bad also at the same time, because you can see that these patients are not straightforward cases. They are very, very sick patients. This is a 56-year-old male patient with 4 months after his MVR for severe MR. In a hypertensive crisis, he went into pulmonary edema. He was intubated in the outpatient clinic. He was on inotropes, and he needed something to be done. He was transferred to our unit. We put him on intra-aortic balloon. We found a severe mitral PVL, so we replaced the mitral valve due to valve rocking motion, as you can see. Another scenario is PVL with aortic endocarditis. This is how we find in a difficult case of aortic endocarditis. And the problem for us is that we have to reconstruct the aortic annulus, which is destroyed by the infection. We need bovine pericardial patches, and in this particular case, we combine the operation with the NICS procedure for the reconstruction, also for the non-coronary sinus of Valsalva. 69-year-old female, 2 months after mitral valve replacement, aortoplasty for dilated ascending aorta plus radiofrequency ablation for AF in another hospital. He was on heart failure with pleural effusion bilateral, and actually we did a redo mitral valve replacement. We replaced the ascending aorta and we excised the membrane because the patient had core triatriatum, and it was not realized by the first operator because he went through the right atrium and not through a left atriotomy. 72-year-old female, 8 months post mitral valve replacement and external grafting of the ascending aorta with bilateral recurrent pleural effusion, New York Heart Association class 3. On chest CT, she had chronic dissection of the ascending aorta inside the graft, which was outside of the aorta. And on echo study, she was on severe mitral PVL with severe tricuspid regurgitation. So we have to redo, we have to replace the ascending aorta. You can see in the left upper how it was, the graft was stuck in the surrounding tissues. You can see the chronic dissection. We simply sutured the mitral valve. We did a tricuspid ring annuloplasty. Another nightmare. 56-year-old male with a history of Bentall operation 10 years before. He was on a huge number of PVCs and heart failure symptoms. He did an unsuccessful redo 3 months before our operation due to false diagnosis of left main anastomosis pseudoaneurysm. This was the CT, and you can see the mass just below the ascending aorta graft. So we have to do the third operation. We did the hemorrhage replacement with hypothermic arrest. We did a Bentall extraction. We closed the PVL and we rebentalled the patient. So you can see that these are very, very sick patients. If you have the unlucky condition to deal with the double valve replacement patient, you should be ready for commando or UFO procedure. As you can see that you have to, in this commando operation, actually you have to open 3 cavities, ascending aorta, left ventricle, left atrium, and reconstruct everything just to host the 2 implants. This is the UFO entropy modification of UFO. What are the results? The results are in big series of Milan, Ottavio Alfieri, 5% for the aortic redo for paravalvular leak and 13% for mitral paravalvular leaks. 1.6% were operated in the same admission because of very early recurrence and unsatisfactory result. Another big series from Canada, 3% for aortic, 8% of mitral, and 14% for double valve procedures. And in this series, it was clearly seen that there is also a PVL recurrence, 3% in the first year and 32% after 10 years. These are results in comparison with the redo, with the general population of redo AVR for many reasons, for many indications. Redo AVRs in Europe, it's 5.1, and redo MVRs, it's between 4.9 and 6.9%. The experience, for me, it is absolutely clear that we have the increased information we have, and from the transcatheter approaches, we have to work together, and this is a very good algorithm that was shown by the previous speaker. What are the comparison from the Montreal group between redo surgery and transcatheter PVL closure is that we, despite the increased perioperative mortality and morbidity, surgery remains associated with better long-term outcomes, mostly driven by reduction in hospitalization for heart failure. So the take-home messages are, these patients are usually very sick patients. The possibility that you will need a demanding surgical procedure is very high. The early results in specialized centers are acceptable, with better sealing probabilities than the transcatheter approach and consequently better long-term results. Heart team approach should always be considered in these patients. Thank you very much for your attention.
Thank you very much, Dr. Panagiotou, for your talk and the very impressive cases you showed us. So complex surgery, really.
Yes,
it's not simply to close the PVL.